great. The attendant here. Hi, Dr. Chu. This
Hi,
is a
Kyle.
patient that the ambulance service just brought in.
Dr. Chu, my name is Ruben. I'm the emergency room resident.
Uh-huh.
Mr. Johnson's a 55-year-old gentleman brought in by the paramedics. They think he might have a heart attack. I just did a confirmatory EKG, and it's my first time looking at it right
Let's
now.
take a look and see what we see here.
Any better with the pain, sir? Okay. Do you have any allergies to medicines?
It looks to me like he's having ST segment elevation myocardial infarction, Ruben. Why don't you go and call the cardiology team, tell them about our patient. I want them to come and do a stat consult as soon as possible.
Absolutely.
Kyle,
Yes.
I think Mr. Johnson's having an ST segment elevation myocardial infarction. Let's just make sure we're doing everything that we're supposed to be doing. I see that he has oxygen on. Has he gotten any morphine?
They got 2 milligrams of IV morphine by an IV that was placed by the paramedics.
Great.
They also gave him 325 milligrams of aspirin in the field.
Perfect.
You've only done the EKG, no other interventions here.
He hasn't got any nitroglycerin?
No.
Well, why don't you start working on that?
But sublingual nitroglycerin?
I think that's great. Actually, he has some PVCs. Is that new?
He had a few earlier, but it seems to be worse. Yeah.
Anna, can you go and get the crash cart for me?
I think it's a sublingual nitroglycerin.
Mr. Johnson, I just want to tell you that we've done some tests, and that chest pain that you're having, we think it might be due to a heart attack. Now, we are giving you medications, and we're doing our... Mr. Johnson?
Mr. Johnson?
Mr. Johnson? Kyle, he's in ventricular fibrillation. Go ahead and start chest compression.
Okay,
I'm going to
compression.
call a code. I'm pushing the code button. I'm going to do pulse checks for you. Hi, I'm Dr. Larry Chu,
And I'm Kyle Harrison.
and we're co-directors of this digital course on crisis resource management in advanced cardiac life support. So the scenario that you just saw had a bunch of great examples of techniques that you, as a healthcare professional, can use in managing crises. Kyle, why don't we just start talking about some of the examples that they saw in this first scenario?
Okay. So if you remember, so as the patient arrived in the emergency room, the attending physician arrives and then gets sign out. Notice how he used names whenever possible so that everyone understood who he was communicating with. As he quickly tried to gain what we call situational awareness, trying to figure out what's happened before and where things are headed, he got a brief sign out from his resident and then dispatched him to contact cardiology as he anticipates and plans for the ultimate need for this patient to go to the cardiac catheterization lab for a revascularization.
Let's pause a second and talk about that, because that's something that I found very useful as someone learning the principles of crisis management. Both the idea of anticipating what you might need and planning for that. Some of that comes from experience, but there's some other things that I think you can just bring into any situation even without 10, 15, 20 years of experience. And one of them is using names. Now, I know I oftentimes hear this this term, thin air comment, where you just throw something out in thin air, a milligram of epinephrine or something like that. And you don't know if someone's actually doing that for you, or people don't know who you're talking to. Now, it seems to me one of the most important resources in a crisis are people.
Absolutely.
And so I think the example of knowing who's in the room means you know who your resources are, and then being able to know their names and address them, I think, is really important. What about leadership in a crisis?
So it's important to establish clear role clarity and clear lead to the team who the leader is. I think it was pretty obvious from this scenario that Dr. Chu was the leader of the event. It started with a small group and then escalated, but by using strong sense of I'm in control, I'm giving the commands, I'm giving the orders, I think anyone entering into that scenario would easily think that Dr. Chu was the leader. There was no ambiguity, if you will, of that leadership. Now, one thing that I thought was good for the learners, I might specifically point out, he dispatched Anna, who was the ED tech, to get the crash cart rather than sending the nurse, because the nurse was more pressing to be getting the medication. So he distributed the workload to the appropriate person. And then once the patient went into ventricular fibrillation, then he assigned the nurse to start CPR while he called the code, because he could then continue to monitor as the people came in. If he was doing CPR, then it would be harder for him to assign roles as they came in. So that was a good distribution of the workload, anticipate and plan, and not getting involved with the procedure as the leader. Now, let's briefly talk about the technical components, because this is both a CRM and ACLS. So patients having PVCs, MI, goes into ventricular fibrillation. So what are our treatment priorities at that moment for this patient?
Well, I think that's a great point. So if the patient is in ventricular fibrillation, the definitive treatment is
Cardioversion or defibrillation.
Defibrillation. But the situation that you saw, there wasn't, and often there is not, any means in which to administer that therapy immediately. So the next step is to obviously begin CPR, cardiopulmonary resuscitation. So you may have seen that, in addition to pushing the code button to get those resources, I instructed Kyle, the nurse, to start chest compressions while I monitored the femoral pulse.
So it'll be interesting. Let's go back and see how they responded. They started compressions. The code team has been activated. Let's see what they did in the further management of this patient.
Yeah, great.
Thank God. Come on,
Anna,
give me help.
thank God you're here.
go.
Mr. Johnson's in ventricular fibrillation. I want you to take
down.
over
Great,
chest
thanks.
compressions for Kyle.
3, 4, ready?
Matt,
and
I
go.
want you to do
And
pulse
take
checks, and I want you to relieve Anna every 2 minutes on the chest compressions.
Dr. Chu, I called cardiology. Anything I can do to help you here?
Reuben, I'd love for you to start managing the airway, see if you can do endotracheal intubation on Mr. Johnson.
Dr. Chu, I got the crash cart here, and here's a cognitive aid if you want it. What do you want me to do with
Kyle,
the crash cart?
I want you to put on the quick combo pads. Let's prepare for defibrillation.
Okay.
I'm going to check this cognitive aid real quick just to make sure we haven't missed anything.
Okay, I'm preparing for defibrillation. Go ahead and continue CPR. I'll work around you.
So you're establishing the airway, 100% oxygen. We're preparing for defibrillation. We need to get some drugs going here.
Paul with pharmacy.
Hi, Paul. I need you to prepare 1 milligram of epinephrine for IV push. Let me know when it's ready. We need to administer it every 3 to 5 minutes.
Right away.
Kyle, how are we doing?
Dr. Chu, I've got the defibrillator ready. Do you want me to charge it?
Yes, prepare
Okay,
for
I'm
defibrillation.
going to charge the defibrillator. Continue compressions. I won't shock you till I tell you. Okay, I'm ready.
Everybody ready? Clear?
Clear.
Clear. Clear. I'm defibrillating. Defibrillation achieved.
Continue chest compressions.
Okay, proceed
Ruben,
to...
we're not going to interrupt CPR for you to get the airway, but proceed with endotracheal intubation.
Sir.
Dr. Chu, I've got
Yes.
1 milligram of epinephrine. Do you want me to give it?
Kyle, go ahead and administer the epinephrine IV push.
Okay. Administering 1 milligram of epinephrine.
I want you to prepare 40 units of IV vasopressin. Let
Endotracheal
me know
tube
when
is
that's
in.
ready.
We'll
and I want you to
confirm.
let me know every 3 to 5 minutes because you're going to have to redo the epinephrine dose.
Epinephrine in.
Okay, perfect.
1 milligram.
Confirming
Flush in.
location for endotracheal tube.
Perfect.
Pressing for you is ready.
Okay, stay on hold on that.
Bilateral breath sounds present.
Okay. Okay, let's check the quick combo pads. Make sure they're connected properly.
Connected. Want me to recharge the defibrillator?
Recharge, prepare for
Okay,
defibrillation.
I won't shock you. I'm going to recharge. Charging.
Okay, everyone clear?
Clear.
Ready for
Clear. Defibrillation. Zoom CPR.
Quantitative CO2 analysis is attached, and we have it.
Okay, perfect.
There is a rhythm change. Do we
Okay.
continue CPR?
Yes.
Just to confirm, Dr. Chu, you want 1 breath every 6 seconds.
Yes.
Okay, so the team has gotten this patient through several rounds of treatment in this ventricular fibrillation. Not sure yet if they saved him. We'll tune in for the resolution in just a little bit. But let's talk about what they've done up to now. So going back to the CRM principles first, and then we'll talk about the ACLS principles. So Larry, what were some of the CRM principles that you saw illustrated in this video?
There was a lot of great examples, I think, in that section. I think probably the most distinctive one that our viewers will have noticed is the cognitive aid. Cognitive aids in crisis management are something new, something that...
new to healthcare, we should say.
New to healthcare, not new to aviation, not new to other high reliability organizations, but certainly to healthcare. And it's something that we certainly think is very useful to aid cognition when used appropriately. And the cognitive aid that you saw was one that was formatted for a mobile computing device, specifically an iPad. And if you are watching this lecture on an iPad through one of our AIM Lab applications, then you should also have that cognitive aid. So that's a cool thing. You can see something that is available on your iPad used in an actual crisis situation. Cognitive aids are great for making sure that you don't miss anything, that you are systematically completing critical steps in the resuscitation of a patient. Obviously, I'm going to mention some limitations of cognitive aids. One of them, obviously, is that you have to pick the right one. So it seems obvious, but it's not actually as obvious as that, especially in a crisis. But if you have a bronchospasm cognitive aid and your patient is having anaphylaxis, for instance, that's an example of choosing the wrong cognitive aid. You may be doing everything on the aid, but it's not necessarily helping the patient move forward with the resuscitation. Something else I'll quickly mention besides the cognitive aid is also closed-loop communication. I think that's critical in a crisis. You may have noticed that when I asked people to do things, when they finished the task, they let me know that they finished it. When I asked for a milligram of epinephrine to be given, after it was given, I was told that it was given. If I asked somebody to do chest compressions, they repeated back to me that they're beginning chest compressions. I think that's critical to help manage a crisis. And Kyle, you might have a few other ones to mention?
Yeah, so let me go back to the cognitive aid one more time to discuss the mention of the wrong cognitive aid. So that would be an example of a fixation error. You fixated on the wrong diagnosis. And this happens all the time with or without cognitive aid. And it's called premature closure. You've kind of locked in on a diagnosis and you've gone down that road and maybe the wrong road. So one of the things you can use as a crisis management principle is to always be asking yourself, could this be anything else? Now clearly you need to commit to the most likely diagnosis and you need to commit to a treatment protocol, but you should always be asking yourself, is this anything else? Could this be anything else? Especially if things aren't adding up the way you think they should be adding up. Always important to always expand the differential. But this is pretty clear, BFib, VT, pulseless VT algorithm, which is a pretty standard treatment. Let me just talk about some of those ACLS principles here. Important that you notice that the team had pretty good communication amongst themselves. It wasn't just the leader, that the other people could chime in at important parts. So the nurse said, I'm going to charge the defibrillator, but I'm not going to shock you. I'll tell you before I shock. Very important, because we know breaks in CPR are detrimental. 10 seconds is too long to stop CPR. So you can't have people pulling off the chest while you charge the defibrillator, because it's going to add 20, 30 seconds detrimental to the patient.
Same thing, you don't pause CPR to establish endotracheal intubation.
Exactly. Absolutely. The compressors are the primary people happening in that scenario. Everyone else works around the compressors.
So if somebody needs to raise the bed so that they can optimal sniffing position for endotracheal intubation, you say, well, actually, we need to help the people performing chest compressions. They're the most important ones. Actually, let me ask you a question, Kyle, while we're talking about endotracheal intubation. Now, I've seen cases where, because of these conditions, people are not able to establish endotracheal intubation. What are the alternatives for the team in that case?
So that's actually important, because it's actually challenging to get endotracheal access. They're doing compressions, the patient's moving, they're often slid to the bottom of the bed, they may be on the floor, they may be stuck in the bathroom. Who knows where these patients are rest. So the most important thing to note is you need effective ventilation with oxygenation, but that does not mean that you need an endotracheal tube. If you're able to bag mask ventilate effectively, you can do that. Alternatively, you can use an laryngeal mask airway, and that's actually encouraged for people who don't intubate. If you're not a regular intubating practitioner, you should not be intubating patients in an arresting situation. You should be bag mask ventilating or using a laryngeal mask airway. And there will actually be a module on airway management in this program that you can review for that. If you are a physician or a nurse practitioner or a CRNA that regularly intubates, try a video laryngoscope, because they can be of assistance in these compressive environments where the patient's moving. With each compression, it can be challenging. But remember, don't fixate that you have to get a tube below the cords. Even if you don't have any access, the old way was you got to get it bound through an endotracheal tube. That's actually fallen off favor now. The appropriate strategy for lost access is interosseous, and once again, we'll talk about that later in this course as well. So don't fixate on the airway. You want to ventilate, but not over-ventilate. You want to keep the ventilatory rate less than 10, 6 to 8, and you want to give short breaths because you don't want to keep that intrathoracic pressure high, which reduces your preload. And just your goal is just to get some oxygen and get some ventilation.
Let's talk a little bit about drugs. We noticed that there was some drugs given that scenario. 1 milligram of IV epinephrine push every 3 to 5 minutes. It's important to redose every 3 to 5 minutes. So what are some strategies that a team, someone leading a team, can employ to make sure that those drugs, such as epinephrine, are given on time when they should be given? What can people do?
So there's sometimes a central clock people can use. The technique that was utilized here was assigning a specific person, so distributing the workload to the person who is most appropriate for that task, which is the pharmacist. They're not going to be doing any other intervention. They can record it, they can alert you, they can prepare the med and hand it off to the practitioner who can then administer it. So appropriately assigning the pharmacist that job. Tell me when we're ready for the next dose every 3 to 5 minutes. Prepare the next appropriate dose, which would be vasopressin. All important that to help move things forward, because you want to, when you're ready for something, you want it there and ready to administer.
Well, I'm dying to see how this all ends, Kyle.
Exactly.
Should we take a look?
Let's take a look.
Okay, guys, it's been 2 minutes. Anna, can you stop chest compressions? Matt, I want you to do a pulse check. Do we have a pulse?
Yes, it's a pulse.
Perfect.
There is
Yes?
a rhythm change. It looks like sinus. Is that correct?
Yes, it is sinus rhythm. That's
have a
great.
pulse.
Hi, you guys.
Great.
From cardiology. I'm good page. What's going on?
Hi, I'm Dr. Chu. I'm the
Check the
attending
blood
here.
pressure.
This Mr. Johnson, he's a 55-year-old gentleman. He came in with crushing substernal chest pain. We thought it was a myocardial infarction. We did a 12 EKG. It showed ST segment elevation. He's gotten morphine, oxygen, and also got aspirin in the field. But he went into ventricular fibrillation. We did have to defibrillate him twice, but he is now in sinus rhythm. He has an endotracheal tube in place, and he should be ready for you guys to bring a cath lab.
All right, let's roll him in.
Well, that's a relief. We
Yeah.
saved the guy.
Thank God.
He got into cath lab. But let's talk a little bit about that. So a couple things were happening. Now, we paused CPR. Now, I remember you mentioned before you should minimize breaks in CPR. So why would we pause CPR?
So you do need to pause to do rhythm assessments, and eventually you may need to do a pulse check.
Can't you do that when you're doing chest compressions?
So you can't do a rhythm assessment with chest compressions because the leads are that smart. All they do is take into account movement. So just like electrical activity, a lead movement gives an artifact. And so everything's going to look like a shock of a rhythm under CPR compressive conditions. So you've got to stop. Now, you need to limit the stops. What you often see in real arrest, people over pulse check, over rhythm check. It's better to do CPR on a patient with a pulse than to not do CPR on a pulseless patient. That's an important point. It's better to do CPR on a pulsed patient than no CPR on a pulseless patient. It's not going to harm them. It will harm them in the other way. So we waited, even though we saw a rhythm change after the defibrillation, we just plowed straight ahead and continued to do CPR until 2 minutes was up. Now, if you have other markers of perfusion, the pulse ox starts coming on. If you have an A-line, it starts competing with your compression A-line. The CO2 suddenly pops up from the low teens to 40. those are all signs that probably the circulation has returned to spontaneous circulation, and then you could stop compressions at that point. But don't do it willy-nilly. Wait to do the pulse checks. So we did.
It's every 2 minutes?
Every 2 minutes.
So, it had been 2 minutes. We stopped chest compressions. We asked Matt to feel for a pulse. There was a pulse.
And then more importantly,
well, now if you have a pulse, then you got to do what?
blood pressure check, right?
Yes.
Because you're now in still a critical care period. The patient has a pulse back. We have no idea how well they're perfusing.
Yes.
If they're still hypotensive, they may flip right back into a lethal rhythm. So stabilize, treat the pressures. And this is actually a point where maybe this is the time to get additional monitoring in. Maybe you want to place arterial line, especially if you're going to be transporting the patient down the hall. It's a lot better to have invasive monitoring than using your finger on the pulse. You can consult with your cardiologist in this circumstance. Do you want us to place a line here, or do you want to just take them to the cath lab and then you'll place it there? But that's a discussion you can have with your consultant.
And let's talk about working with consultants. So we saw at the end the cardiology consult did come. When we work with consultants, there's obviously a process that we have to go through for transferring care, at least providing a brief but thorough enough history so that the cardiology team could take over, letting them know what had happened, how many times, what rhythm the patient had gone into, the actions that we took, how many times we had to defibrillate, the drugs that we gave, a milligram of epinephrine, the fact that the patient was now in normal sinus rhythm and had an intratracheal tube in situ. All important things so that the cardiology fellow could quickly do the next therapeutic option, which is bring Mr. Johnson to the cath lab.
Right. So this is the mnemonic people will use sometimes. It's called SBAR. So situation, what's happened, background, what's the background on this patient, what's the assessment at this moment, and what the recommendations are to the signing out provider. Now, our recommendation at the team was to take this patient to the cath lab, and they kind of volunteered that before, so the recommendations were in jive. We didn't have to say it because they said it for us, but remember that SBAR can help transfer information to teams, which is important.
Great, so let's put it all together and wrap up for this episode. I'll start just by summarizing some of the principles of crisis resource management that we've seen. You're going to see these principles revisited throughout our digital course that we go through, and you're going to learn about some new ones. But the first thing is to remember to always designate leadership. That was clear, I think, in this case, not necessarily so clear in other situations that you encounter, but make sure people know who the leader is, because without leadership, we're not going to be able to maximize the use of resources in a crisis. Obviously, also call for help early. As soon as you know you're in a situation where you're going to need help, you have to begin to mobilize those resources. Anticipating and planning, calling for a code card, or calling for a cards consult. All of these things are important. Distributing workload. We noticed how when I did need the crash card, I sent the tech, because I knew that this was a patient who could potentially be unstable. I would need somebody with higher level medical skills, such as a nurse, with me to do things like resuscitation, like chest compressions. So distributing the workload appropriately, I think that was another key lesson that we saw here. Obviously, communication is so important in a crisis. Communicating effectively. The use of closed loop communication, so that when I ask for something, I don't use thin air communications, but I say, Anna, I need the crash card. And then we hear back, crash cards here for closed loop communication. And of course, you saw for the first time the use of cognitive aids. And you'll learn more about cognitive aids in crisis as we continue this digital course. But these are just some of the principles you learn in this episode. Kyle, do you want us to talk a little about the advanced cardiac life support principles that we learned here today? So
reviewing, it's CAB, it's the new way, it's no longer ABC, it's compressions first, followed by airway. It's immediate, as early as defibrillation as possible, but you always start with compressions first. If you're able to get the defibrillator quickly within the first few minutes, you can defibrillate prior to epinephrine. If patient's been down for 2 to 3 minutes, you want to give epinephrine before you attempt defibrillation. You continue CPR all the way through winding up the defibrillator and only clear people right for the defibrillation, then right back on the chest. Don't do pulse checks frequently. Always go right back to compressions after the defibrillation, repeating the cycle of defibrillations, drugs, being epinephrine, vasopressin one time, and then shock, CPR, once they get the patient back, you monitor for further instability, stabilize the blood pressure, and then provide definitive treatment, especially in a patient like this who's having a myocardial infarction, needs to go to the cath lab. Once again, this is our VFib VTAC scenario. We're going to go over others throughout this course to get you fully versed in ACLS and pepper in all these crisis resource management principles. But hope you've enjoyed this module, and we look forward to you seeing future modules.
Great. We'll see you next time.
Okay, bye-bye.